Good morning, ladies and gentlemen. I'm Tae Hee Kim from Aju University School of Medicine from Korea. And it's very honored to be presenting at Vietnam Radiology Conference. It's my second visit to Da Nang. And today's topic is breast imaging after conservative breast cancer treatment. According to the Korean Central Cancer Registry in 2019, about 30,000 women were newly diagnosed with breast cancer, and the crude rate for breast cancer was 115 per 100,000 women. The median age of women with breast cancer was 52 years old, and breast cancer was most commonly diagnosed in the age group of 40 to 49 years. I heard that this distribution is very similar to Vietnam women. And the proportion of patients with stage 0 or 1 disease increased from 38% to 61% in 2019 because of the screening program maybe. The incidence of early stage breast cancer continues to increase. The number of patients who have undergone breast conserving surgery has continued to increase since 2016, with nearly 70% of patients undergoing breast conserving surgery in 2019. When performing breast conserving surgery, it is very crucial to achieve a negative surgical margin and ensure that no cancer cells remain in the breast. To achieve this, various techniques and procedures are utilized, such as US-guided skin marking, needle localization, and clean marker insertion. We do many US-guided skin marking and needle localization before the breast conserving surgery. For example, in the preoperative breast MRI, there was an index cancer and there is small satellite lesion. The patient have planned to breast conserving surgery, so we did the US-guided skin marking for the index cancer and small satellite lesions. US-guided needle localization was frequently performed for non-palpable lesion, frequently less than 1 centimeter lesions, like this. So we did US-guided needle localization, and we confirmed the location of the needle tip. And after breast conserving surgery, we did specimen mammography. For the patient with neoadjuvant chemotherapy patient, for example, this is the pre-chemotherapy mammography. There is a large mass, and we did US-guided clean marker in the both margin of the mass, like this. And there are so many complete response patients. In the case like this, there is no residual mass like that. So these inserted clips may be useful for the operation and for surgeons. This patient was underwent breast conserving surgery for left breast cancer. After 4 years mammography, post-follow mammography, there's no specific lesions on mammography. But post-op MRI was like that. There is less than 1 centimeter small enhancing mass, just lateral aspect of the post-op scar. So we did ultrasound, and there was a post-op fat necrosis, and there was small record mass in the just lateral aspect of the post-op scar. Like this, MRI can detect small recurrence that cannot be visualized on mammography. So according to the American Radiology Guideline, for women with a personal history of breast cancer, annual mammography is recommended. For women with a personal history of breast cancer, especially in dense breast or younger patient before age 50, annual surveillance with breast MRI is recommended. In the National Comprehensive Cancer Network guideline, They define the average risk and increased risk. Average risk means you have no known genetic or family history that suggests you are at increased risk of developing breast cancer. It is recommended you have annual screening mammogram starting at 40 years of age. And increased risk means a strong family history of lifetime risk is more than 20% calculated using risk assessment tool such as Gale or Tyrer-Cushing model, and chest radiation therapy or more fiber risk of invasive breast cancer or ADH, LCIS or ALH, and genetic mutations. These patients are defined as increased risk. And for those at increased risk, annual screening mammography may start as early as 30 years of age. And for those at increased risk, annual breast MRIs may start as early as 25 years of age. This study was published in JAMA Oncology from Korean multicenter study, which compared the effect of mammography plus MRI or mammography alone for patients with breast conserving surgery younger than 50 years old. And the result was cancer detection rate was 8.2 versus 4.4 per 1,000 women. And the sensitivity was higher in mammography plus MRI, and the specificity was slightly higher in mammography alone. Here is the various cases with non-mass investment on post-operative MRI. This patient underwent right breast conserving surgery for right breast IDC plus DCIS. And post-op 4 years MRI, there is newly developed small nodules and clumped non-mass investment in right breast, like this, small nodules. But these lesions were not visualized on post-op mammography and post-op ultrasound. This is the post-op scar change in the breast conserving site. So, but on MRI finding was so suspicious for malignancy, so we did a surgical excision, and the result was invasive ductal carcinoma with DCIS. So many non-mass investment is only visualized on MRI. This is another case. This patient underwent right breast conserving surgery for right breast IDC. In post-op 2 years MRI, there are some small nodules here. And after 2 years from that, the clump non-mass investment is increased in size, and the number of small investing nodules also increased. So, like this, there are small nodules here. So we considered this to be maybe recurrence. What is your diagnosis? DCIS or UPE? So we performed US-guided corneal biopsy for these lesions, and the result was benign ductal epithelial hyperplasia. And from this, after 2-year follow-up MRI, these lesions regressed and confirmed as the physiologic background parenchymal enhancement. This patient underwent bilateral conserving breast surgery for right DCIS and left LCIS. In post-op 2 years MRI, there was no specific lesions, but in post-op 3 years MRI, in left side, there's new clump non-mass investment and small nodules like this. And CAD stream. This software is for measure the early or delayed kinetics on contrast-enhanced MRI. So blue means the delayed persistent, and yellow means the delayed plateau, and red means the delayed washout pattern. So we found these lesions on ultrasound, but there are several small nodules looking benign, but this was so suspicious finding on MRI, so we did US-guided corneal biopsy, and the result was invasive lobular carcinoma. This patient also underwent left breast conserving surgery for left breast IDC. And post-op MRI after 2 years, there is diffuse parenchyma enhancement in right breast, so we considered it as physiologic BPE. But 2 years after, the diffuse parenchyma enhancement disappeared, but regional distributed heterogeneous enhancement remains. What is your diagnosis about that? DCIS or physiologic BPE? I think it's a very difficult case. And at that time, we considered it as BPE, and on a follow-up MRI, the lesions disappeared. It is the typical difficult cases of anomalous enhancement on MRI, especially in premenopausal women. This patient underwent left breast conserving surgery for this left DCIS. And in post-op 2 years MRI, new focal clump anomalous enhancement developed in left breast. We did second look US for this lesion, but there was no visualized lesion on ultrasound. So we did MR-navigated ultrasound. This is the MR-navigated ultrasound systems in our hospital. So this is the magnetic field generator, and this is the position sensor unit, and this is US probe with magnetic sensor. So for the MR-navigated ultrasound, supine position MRI should be performed, and supine position MR images were loaded in the ultrasound machine in this monitor. And when the examination with the probe movement, the correlated MR moves simultaneously. So we can find the MR correlated lesion on ultrasound. And like this, with the spine MRI, this clump anomalous enhancement was visualized in here. And we did the MR-navigated ultrasound, and we find the MR correlated lesion on ultrasound. Without MRI, maybe at the time we thought that this is maybe more benign ductal structure or normal fat, but by MR-navigated ultrasound, we can do US-guided biopsy for this lesion, and the result was DCIS. Let me show the lymph node cases. This patient underwent right breast conserving surgery for IDC, and initially there was a borderline size internal mammary lymph nodes. The criteria maybe is reported to 0.6 centimeters, and this is very equivocal finding in the initial MRI. But post-op 2 years MRI shows the size was decreased, maybe because of the systemic therapy. But after 3 years, the lymph nodes start to increase in size, like this, and the final result was lymph node metastasis. MRI is very useful for the evaluation of internal mammary lymph node. This patient underwent left side total mastectomy, and in follow-up chest CT, there were new enlarged lymph nodes in left internal mammary and left axillary area. So she underwent PET-CT, and the SUV max was 2.4, the left internal mammary lymph node. On MRI, the lymph node was enlarged and very strong enhancement. And on T280 image, the signal was high. So we considered this node to be lymph node metastasis. But for the US-guided FNA, we did ultrasound, and the lymph nodes appeared hyper-echoic like this. And this is the typical finding of silicone-laden lymph nodes in silicone-implanted patient. Yes. So the FNA result was multinucleated giant cell and foreign materials, clinically silicone. This patient underwent right breast conserving surgery for this cancer, and the final pathology was isolated tumor cells in the permanent slide in the axillary lymph node. In the post-op 1 year ultrasound, there is no specific finding except benign-looking lymph nodes. In post-op 2 years ultrasound, there was some architectural distortion, and the doctor at the time thought that this is common finding of surgical excision scar in the axillary area after lymph node dissection. In post-op 3 year, the architectural distortion increased in size. And at that time, the doctor also thought that this may be the architecture, post-op surgical scar in the axilla. But after that, the lesion increased in size and definite mass in here, and the biopsy was recurrent ductal carcinoma. When we do ultrasound in post-op women, this finding is very common. So it is difficult to think this is recurrence, but during follow-up, close check for size increase is important. Yes, let me show the post-op scar cases here. This patient underwent breast conserving surgery for right medullary carcinoma initially. And post-op ultrasound, this is common finding of a post-op scar and some serous fluid collection like this. After that, also common finding of a post-op change. And after that, also it is very common finding of post-op change. But after that, there was volumetric hyper and hypoechoing mass-like lesions within the scar. So the change is like that. Initially, post-op fluid, but now there is irregular mass-like lesion on chest wall and low dark signal intensity on pre-contrast T180 image. And after contrast enhancement, there are heterogeneous enhancing mass here. So we did biopsy for this lesion, and this was proved as post-radiation angiosarcoma. Angiosarcoma could be primary or secondary, and this patient was secondary after radiation therapy, usually 5 to 7 years after the radiation therapy. So the secondary angiosarcoma could be presented as skin thickening or small nodule, enhancing nodules in the skin. So it mimics the routine post-op change, and it can delay the diagnosis of radiation-induced angiosarcoma. This patient underwent left breast conserving surgery for this IDC in left breast, and similar finding with the previous patient. There was post-op fluid here, but there was new isosignal intensity mass, and that was strongly enhanced in hypoechoing mass-like solid portion within the scar. So we did biopsy. Is this also post-angiosarcoma? But the result was fibrosis with vascular proliferation. Maybe this benign finding is more common than radiation-induced angiosarcoma. About the new small nodule in the follow-up MRI, this patient also underwent left breast conserving surgery for left IDC. In post-op 4 years MRI, there is new small enhancing nodules. And with the CAD stream evaluating the delayed kinetics, there was delayed washout pattern within the mass, and we did a second look US or targeted US, and we find small nodule, and biopsy was DCIS. When we evaluate the small nodule less than 5 millimeters on MRI, we should evaluate the margin first. If the margin is irregular, we should biopsy, of course. And when the margin is circumscribed, then we should evaluate the T2 signal. If the T2 signal is high, we can consider it as more complex cases like that or other benign lesion. But the T2 high signal is not visualized on MRI. And then when the mass shows reminiscent, we should biopsy. And the mass does not show reminiscent, we can follow 6 months after 6 months. This patient underwent left conjuring surgery, and on post-op 2 years follow-up, there are no nodule less than about 5 millimeters, and a subtle reminiscent, and this nodule does not show high signal intensity on T280 image. So we did a targeted ultrasound and small irregular nodule, and biopsy result was the CIS. Another case.
Excuse me. It's time now.
Oh, yes, sorry. So, yes, similar cases like that. So I will show the typical images. Yes. This was small irregular mass and small persistent and plateau and washout patterns. So this was proved malignant lesions. So my conclusion is breast MRI is helpful in the preoperative evaluation of cancer extent for breast conserving surgery and for post-op evaluation in patients with dense breast or younger than 50 years old. 2 days ago, I visited Hue City, and this was very peaceful and beautiful place. And,